presented by Northwestern University Feinberg School of Medicine at OMed Live. You are tuned into the live session, The Challenges of Prostate Cancer Survivorship. My name is Dr. Matthew Smith. I'm a professor of medicine at Harvard Medical School and a medical oncologist at Massachusetts General Hospital Cancer Center. Before we get started, I'd like to remind you that today's session is a live interactive program that allows me to take questions in real time throughout this presentation. I sincerely encourage you to send your questions anytime by typing them into the box located at the lower left-hand side of your screen. This interactive part of the program will really, I think, make this for a more instructive experience, certainly make my afternoon more fun. So let's get started. The focus of today's presentation is challenges in prostate cancer survivorship. What I'd like to do today is briefly review the evidence supporting the use of androgen deprivation therapy and then spend some time talking about the impact of that treatment on men surviving prostate cancer. Androgen deprivation therapy is the mainstay of treatment for metastatic prostate cancer. It also has an important role in the management of many men with non-metastatic disease. It's important to remember that androgen deprivation therapy has well-established benefits, including improved survival in specific clinical settings. It's important also to note, though, that many studies have shown that androgen deprivation therapy use in the community is often in settings that are categorized as either inappropriate or discretionary. This is important because androgen deprivation therapy has a variety of potential harmful effects, and these side effects will be a substantial part of our conversation today. Androgen deprivation therapy results in accelerated bone loss and greater risk for osteoporosis. ADT has other body composition changes, including obesity and sarcopenia. And androgen deprivation therapy is associated with greater risk for clinical fractures, diabetes, and in some studies, greater risk for cardiovascular disease. The androgen receptor pathway, is a validated target in prostate cancer. The male testicles make testosterone. The additional source of testosterone or androgens are the adrenal glands. And testosterone and other androgens act by binding the androgen receptor in the cytoplasm and following nuclear translocation, activate a panel of androgen-responsive genes. These genes are involved in the normal growth and regulation of the prostate and play a central role in the development and progression of prostate cancer. Androgen deprivation therapy has established survival benefits in certain clinical settings of non-metastatic prostate cancer, including adjuvant therapy for node-positive disease after prostatectomy, as well as combined modality therapy in men receiving radiation therapy for high-risk disease. This slide shows data from EORTC 22863, arguably some of the best available data showing a survival benefit for prostate cancer in non-metastatic disease. This study included men with high-risk locally advanced prostate cancer. They were randomly assigned to either radiation therapy or radiation therapy plus long-term androgen deprivation therapy. And as you can see, men who received combined modality therapy enjoyed a substantially better survival. The number needed to treat in this study was 3, meaning that for every 3 men who received additional androgen deprivation therapy, 1 death was prevented, in this case, at 8 years. In the field of oncology, this is a very large treatment effect and, of course, establishes this as the standard of care for men receiving radiation for locally advanced and high-risk disease. This information, though, has been generalized to other clinical settings in prostate cancer, including intermediate and low-risk disease. And here, too, we have evidence about potential benefits. Short-term androgen deprivation therapy does improve survival in men receiving radiation therapy for intermediate-risk disease. In this large RTOG study of about 1,000 men with intermediate-risk disease, combined modality therapy was associated with improved survival compared to radiation therapy alone. You'll note that the magnitude of the benefit was somewhat smaller, with a number needed to treat of 17. Again, this means that for every 17 men who received androgen deprivation therapy, 1 death was prevented at about 8 years. In low-risk disease, though, there is absolutely no evidence of benefit for the addition of androgen deprivation therapy. And that red call-out box I failed to mention here says, even with intermediate risk disease, about 9 out of 10 deaths result from other causes, pointing out the importance of considering competing risks in all of our patients. In low-risk disease, there is no evidence that androgen deprivation therapy improves survival in those receiving radiation therapy. In the same study of RTOG 9408, for example, there's no benefit for the addition of radiation therapy to men receiving radiation for low-risk disease. Accordingly, the number needed to treat was infinity, and 94 out of 100 deaths resulted from other causes, again, highlighting the importance of considering competing risks. And this point will become, I think, particularly important as we consider the potential adverse effects of androgen deprivation therapy, particularly when we're considering its use in these discretionary settings. Now, large population-based studies have looked at the issue of the appropriateness of androgen deprivation therapy use. And these terms, by the way, are not my terms, but the terms used by the authors of this manuscript published in New England Journal of Medicine. They used SEER Medicare data to look at use of androgen deprivation therapy in men with prostate cancer, and then considered the appropriateness of the use based on the setting. So for the purposes of this study, they deemed androgen deprivation therapy in combination with radiation for high-risk disease as appropriate, based on the evidence I just described. And you can see at the beginning of the study period, the rates of that appropriate use were relatively high and then increased over time. And I think we can attribute much of that increase as the mounting evidence supporting the use of combined modality therapy in high-risk disease. Notably, though, they also found substantial rates of inappropriate use. And in this study, they defined inappropriate use, one of the settings for inappropriate use, as primary androgen deprivation therapy for well or moderately differentiated T1 or T2 tumors. So we're looking at really primary ADT for mostly low-risk disease. And you'll note that there was a substantial rate of such use at the beginning of the study period, and that continued throughout the period of observation, despite growing evidence both about the lack of benefit in that setting as well as mounting concerns about the potential harms of treatment. So we really all need to be mindful about these issues when we're making decisions for individual patients. And this is important because testosterone has a variety of normal physiologic functions in men, and some of these are summarized here. Testosterone and other androgens are important to the brain. They support sex drive, positive mood and energy, important in red blood cell production, maintenance of bone mineral density, has an important role in maintenance of other components of body composition, including muscle size and strength, obviously has an important normal role in sexual development and reproduction, also has other roles, including, for example, in growth of body hair and maintenance of skin health. Osteoporosis is an important problem in men. Like their female counterparts, older men are at risk for osteoporosis and fractures. This is a Netter diagram showing the consequences of progressive vertebral fractures with loss of height and increasing curvature of the spine, resulting in the characteristic functional impairments we associate with advanced osteoporosis, including a stooped posture, impaired respiratory biomechanics, and an impaired gait. Turns out that about 1 in 4 hip fractures occur in men, and much like their female counterparts, men are at greater risk from death following a hip fracture. So this is an important general problem in men's health. We make that problem worse with androgen deprivation therapy. This slide shows the rates of fracture by gender and age. If you first focus on the right, you can see that the rates of hip and vertebral fractures increase progressively as women age, with a steep inflection point corresponding at about age 50 due to the onset of natural menopause. Men, too, have the steep inflection with the increase in risk for hip and vertebral fractures with age, although that inflection point occurs somewhat later, we assume because of the lack of natural andropause in men, or at least lack of dramatic andropause in men. We make this